Testicular cancer is the most common malignancy among males aged 20 to 40 years old, and it is the second most common malignancy in young men 15 to 19 years old. However, testicular cancer in general is not common, and it is estimated that 1 out of 250 males will develop testicular cancer in their lifetimes. Other male specific cancers are prostate cancer and penile cancer. The testicles have two major functions. First is to produce spermatozoa through spermatogenesis, and second is production of testosterone. There are different types of cells responsible for each of these functions. Let us now look at the different cells in the testes. The testis is divided into two compartments. The first one is the seminiferous compartment, which contains the germ cells and Sertoli cells. The germ cells differentiate into spermatozoa, while the Sertoli cells envelop the germ cells. The second compartment is the interstitial compartment. It is here where we can find the Leydig cells. Leydig cells are the main source of testosterone among males. The most common type of testicular cancer are germ cell tumors. 95% of testicular cancers are of germ cell origin. The different types of germ cell tumors are seminomas, which accounts for 33 to 50% of all germ cell tumors, embryonal cell neoplasms, which includes yolk sac tumors, responsible for 20 to 33%, teratomas, 10%, and glassis choriocarcinoma, which is the rarest form, accounting for 2% of cases. Non-germ cell tumors are derived from Sertoli cells and from Leydig cells. These tumors can secrete hormones which can cause other signs and symptoms. Sertoli cell tumors can cause gynecomastia and feminization due to excessive aromatase activity. Leydig cell tumors may produce in children sexual precocity, rapid skeletal growth, development of secondary sexual characteristics, and in adults, tender testicular mass and tender gynecomastia. The treatment of testicular cancer varies. Seminoma is treated with radical orchidectomy and radiotherapy. Chemotherapy may be added for metastatic disease. Non-seminoma, on the other hand, is treated with orchidectomy and retroperitoneal lymph node dissection. Radiotherapy or chemotherapy may also be done if needed. Non-germ cell tumors, such as Sertoli and Leydig cell tumors, are treated with unilateral radical inguinal orchidectomy. Mitotane has been shown to benefit patients. Prognosis of seminomas are relatively good. 98 to 100% 5-year survival after orchidectomy and radiotherapy for localized disease. For patients with lymph node spread below the diaphragm, the survival rate is slightly reduced to 80 to 85%. And for those with disseminated disease, survival is at 70%. Non-seminomas, on the other hand, have lower survival rates at 20 to 60%. Leydig cell tumors have poor prognosis. Early detection and diagnosis is key to increase the survival rates of patients diagnosed with testicular cancer. Therefore, it will be beneficial to do a self-exam or a testicular self-exam. This is usually done after showering so that the scrotum will be relaxed. The testicles are checked one at a time and both hands are used. It is done by rolling one testicle gently between the fingers and thumb of both hands. The back of the testicles are checked to feel the spermatic cords. And we should look for lumps, change in size, or pain. If any abnormality is observed during testicular self exam, consult your healthcare provider immediately.